Hey, everybody, welcome to the Home Care Forum podcast with your hosts, Sasha, Guillaume, and Emina Poricanin. Amina's traveling, as I guess, as am I this week. And sadly, I'm in Costa Rica while Theo, Malcolm Jamore Warner, past Costa Rica, is a surfing country, and therefore the waves can be great for that, and yes, yet dangerous. And I was sorry to hear that he passed. So, Amina, how's it going in your travels? And here you have a lot to speak to about what's going on in home care and your conversations in the industry.
Hi, Sasha. Hi, everybody. Thanks for tuning in. I am away, but I'm actively working as I'm traveling. So I wanted to share with you some of the, I guess, common questions and issues that are coming up with providers in the industry, because I do believe that those are representative of what other providers are going through as well. So before we jump into those day-to-day type of questions, we wanted to just highlight some updates. Number one, the Office of Medicaid Inspector General has published updated audit guidelines for the NHTD program. As we know, the NHTD program has been subject to a lot of scrutiny over the last several months as the program has grown and the rates are a lot better than the MLTC rates, leading to its increasing popularity and the state's fear that that program will start costing the taxpayers a lot of money. So we've seen efforts to rein that in. A lot of providers, like Sasha, do experience significant hold times to get people enrolled in that program. All of that is part of the state's effort to clamp down on the growth. But these audit guidelines have been updated. I do have some providers who are undergoing NHTD audits. They are not as frequent as the just personal care services audits, but just from my experience, they could be pretty costly as well. The OMIG really focuses in on things that you would see in a typical LICSA audit. They want to make sure that the caregivers on those cases are properly background checked, trained, immunized, and supervised. And if they're not, as many of you know, there will be a finding based on a sample of audited charts, and then that sample and the errors will be extrapolated. So what may have been 3 or 4 instances of violations based on the sample charts is going to get multiplied through this extrapolation methodology that the OMIG uses, and you're going to get a much bigger bill for a discrete few issues that they identified in their sample. So, as all OMIG audits, take these very seriously. It is important to work with the auditors on what exactly they're needing and what they're missing. There are many cases where they will accept alternate documentation. They, meaning OMIG, as well as the Department of Health, often takes the approach that unless it's documented, it hasn't happened. So certainly the original documentation, whether in hard copy or electronic format, is typically ideal. There are ways to retrace the steps and prove that something did happen. For example, that a specific training was held through other means. So work with your counsel to make sure you're checking all of the boxes on these audits as things are happening. It's better to convince the auditor of your compliance in the midst of the audit versus at the end, later during the exit conference when they're presenting their findings. So those are pretty significant updates. Sasha, what do you think about that?
Yeah, I mean, look, I think the NHCD program needs to be looked at, and associations and agencies need to partner with the Department of Health to try to mitigate the risk of us losing the program. And I think the NHCD TBI Alliance is actually doing a great job of that. They sent the update of the last meeting. I was unable to attend because of international travels. But the notes on that speak to the cap that's coming. It's going to be 3-year enforcement. They're waiting for approval, but it will be retroactive to July 1st. And the cap of 9,400 is in place. We're just shy of 9,000 members currently. So that we are quickly approaching that cap, and once that cap is reached, there won't be any new persons allowed into the program. There is no wait list. The idea is that once the members come off of the program, then there will be allocated, distributed by percentage throughout the state. So about a little over 400 patients right now come off of the program annually, and therefore that's what you're going to look to as possible replacement, and those who can come onto the program on an annual basis. Other ways of saving costs is to potentially make the NHTD program more difficult to qualify for, where the state could look at other solutions, whether it be a CDPAP was floated, live-in service versus NHTD, which is a split shift situation, but basically keep the services in the managed care program as much as possible in lieu of direct Medicaid, which is a costlier program. That's a bit disheartening, understanding what just happened with CDPAP, and that becomes an option to this program, which is more intensive, right? This program is for those who would normally be in a nursing home. And yes, you can train your personal assistant to do some of these tasks that a nurse would do. One of the great things about this program is the care management aspect of it, where nurses can go in. Nurse time is paid for, and therefore you can get that service in the home at a higher level. But look, we have to understand that something is going to be done. And right now they've made the decision, but we need to be in the room earlier and discussing. So I'm glad the Alliance is having these conversations, and I encourage other associations to continue and take from them. That is a great way to do it.
Well, so the associations are meeting with the Department of Health. There are stakeholder groups that have been invited to participate with the Department of Health to review how the budget limits for NHTD can be met without sacrificing the quality of the program. And so there was a meeting, the second meeting of this stakeholder group just recently held. Now, pivoting from this a little bit, there was also a meeting held with the Managed Care Policy and Planning team. They meet monthly with the Department of Health, and some of the home care groups are invited to participate in these meetings. Behavioral health was discussed. OMIG compliance reviews were discussed. Once again, the Bureau of Managed Care Fiscal Oversight was participating in the meeting and reviewing funding for the MLTCs. Of note, as we've discussed before, KeyVAP, enhanced KeyVAP, was removed from this year's budget. The standard baseline KeyVAP is still there, and the new numbers will be released pretty soon. But the enhanced portion, once again, it was reaffirmed at this meeting that it would not be coming as a result of elimination in this year's budget. I'm not sure if I mentioned it, but there was an update to the FAQs related to social adult daycare centers. And so MLTCs and social adult daycare centers occasionally submit questions to the Department of Health. And so those FAQs have been updated now and are available online on the DOH website for anybody who operates a social adult daycare center. Let's talk a little bit about the PPL litigation. Since we last recorded an episode, there has been a lot in the news. The president has stepped down and she has already been replaced. I believe she will officially be out in about 60 days from today. So she's out. And then there was a very damaging post report that an inside employee of PPL has been embezzling money, a lot of money. Sasha, you saw that, right?
I actually didn't. I saw the stepping down, but I didn't hear any thing about the embezzlement, which
Oh, it was everywhere. It was everywhere. I mean, it just the hits just keep coming. Now, the group that was initiated by Rivera to examine the success of this program, the single FI program, to my knowledge, they have not yet met. They were supposed to, and at the request of the Department of Health, the meeting was postponed because the department wanted to participate and get their thoughts in order for this meeting. I don't think anything good has come up since they postponed the meeting in order to put their thoughts together. If anything, they have more to answer for. But, I had a conversation a few days ago with a reporter from ABC News, and I should really post the link to the TV news story that came out. But they were asking me about the PPL litigation that I commenced related to wages not being paid correctly for these workers. I have seen since that there was a separate story that ran about wage parity and Leading Edge being the wage parity administrator for PPL standing to make millions of dollars off of unused wage parity benefits. Hint, Department of Health, if you're listening to this, there are millions to save in this program if you would just oversee things a little bit better. But PPL has moved to terminate or dismiss, as more formal language should be used. PPL has moved to dismiss my wage and hour class action because it is too complicated for them to try to justify why they have underpaid all of these workers given the variations in different consumer schedules. That is not a valid basis to dismiss a case. Secondly, they have moved to dismiss my entire class action on the basis that the patient consumers should have been joined as defendants in the action. This is very false because we can certainly resolve any underpayment issues and wage underpayments without the consumer's participation. That's a little bit annoying that they moved to dismiss, but it's okay. I don't think they're going to win. What I think annoys me a little bit more is that they actually could have made some legitimate arguments and dismissed some of my claims, but they didn't. Clearly, they don't have very competent counsel. And I'm debating at this point whether I should file for sanctions or get my attorney fees paid because they're wasting mine and the court's time by moving to dismiss a case on frivolous grounds, meanwhile neglecting very, very meritorious grounds for dismissal. We shall see. We shall see what comes of that. But my motion is due to be filed, or my response to their motion to dismiss is due on Thursday. So, among other things, keeping me busy, I've been working on that. Any feedback on that, Sasha? I mean, you're out of the CDPAP program at this point entirely, right? I mean, there
yeah.
is that litigation still that's has some residual authority for providers to provide CDPAP, but I think you're out.
Yeah, no, I mean, there's no service being provided. We're at this point, all we're doing is trying to collect whatever receivables that we have, I don't think there's any turning around. The damage is done. If this thing gets overhauled, you're starting over, right? So,
Yeah. Hmm. Well, for those people that sign subcontractor agreements with PPL, you know, to be determined whether they're making any money on that, but they have a deadline of October to divest their interests from the LICSA. So if you remember, the DOH came out with these requirements that never passed into law, that a subcontractor cannot be a LICSA and an FI or a subcontractor. to an FI, and that there cannot be any common ownership between the LICSA and the FI or an MLTC. So a lot of these LICSAs that are subcontractors who were providing FI services now have to divest themselves of their interests in the LICSA, which is really bizarre to me because the contract that they all signed with PPL creating this obligation in the first place is with the entity that is supposedly supposed to be divested. Like it doesn't make sense. So we will see if the department will actually enforce that. There's no statutory or regulatory authority for them to force these businesses to just separate out into two businesses. There's none. But at the same time, a lot of these providers who are working as subcontractors are wondering, what am I doing now? Do I move to create another entity that will be the subcontractor and then move my contract over there? And who owns that second entity?
Yeah, nothing seems to matter anymore. Things are just in law, and sometimes it matters, sometimes it doesn't. So we will wait and see. Do we want to pivot and speak about the CMS calendar year 2026 proposal?
Go for it.
Proposed
All
rule.
you.
Right. So what I'm about to say is a bit confusing for me, but to me, it sounds like Washington math, right? Where CMS has released their calendar year 2026 proposed rule for Medicaid home health prospective payments. Now, there's a proposed rate reduction. They want to citing efforts to balance expenditures on the patient-driven groupings model, right? Implemented in 2020. Now, this would mean a 6.4 national reduction or $1.135 billion less in Medicare home health funding. Okay, that is bad, very bad for the industry, right? But then in the CMS finalized rule of calendar year 2026, the Medicare Advantage Part D rule, a CMS released that the final rule is that there could be an increase in payments of a little over 5%, more than double the 2.23% previously proposed by the administration. So this could mean that for those who have Medicare Advantage, there can be more money going to that, and for those providers who are able to provide services for Medicare and Medicaid patients, there could be more monies, right? So that's what I'm saying is Washington math. There's cutting on one end, and then an increase on another end. Yet it's unclear. We need more information from that. But there are opportunities to expand partnerships with Medicare Advantage plans for in-home care providers. Okay, finally, we will close with a bit of good news for home care providers, where effective July 31, New York employers will no longer be required to provide paid emergency leave for COVID-19 related quarantines and isolation. I don't think that we had much of this, but we are still tracking. COVID numbers are going up. Tracking by I mean the weekly numbers that we have to provide to the state. So we know that this is a thing that still is affecting us nationally. But after the state's employees seeking leave for COVID-19 related reasons must rely on existing statutory leave entitlements, including paid sick leave, including New York paid sick leave, New York paid family leave, or the New York City Earned Safe and Sick Time Act, right? So regular PTO and those leave options are all that they will have at their disposal, unless something else happens, unless another pandemic. But that is it. Hopefully not. Emina, thank you for joining on your time off. Everybody, thank you for listening. This has been the Home Care Forum podcast with your hosts, Sasha, Guillaume, and Emina Poricanin. Have a good one.